My name is Attila Feher, and I'm an advanced cardiovascular imaging fellow at the section of cardiovascular medicine at Yale University. On behalf of my co-authors, today I'm glad to present our paper entitled Impaired Myocardial Flow Reserve on Rubidium Positron Emission Computed Tomography in Patients with Systemic Sclerosis. The coronary microcirculation represents small intramural vessels with intraluminal diameter less than 500 micrometer. In the absence of epicardial coronary artery disease, the myocardial flow reserve is really an indirect measure of coronary microvascular function. The myocardial flow reserve is calculated as the ratio of myocardial blood flow during pharmacological stress compared to rest myocardial blood flow. The normal myocardial flow reserve greatly depends on age and gender. However, it is well accepted that a myocardial flow reserve less than 2.0 is low enough to result in ischemia, and the myocardial flow reserve less than 1.5 is associated with poor outcomes. To date, no studies have investigated the relationship between Raynaud phenomenon and coronary microvascular disease by PET myocardial flow reserve assessment, which is really a gold standard for the assessment of coronary microvascular disease. We hypothesize that secondary Raynaud phenomena may be associated with reduced PET myocardial flow reserve. In order to investigate this, we have conducted a retrospective core study where we identified 49 patients with diagnosis of Raynaud who underwent rubidium PET myocardial perfusion imaging at Yale New Haven Hospital. And we compared these patients to two set of controls, 14 healthy volunteers without any coexisting medical conditions. And also we compared the patients to a matched control group of 49 patients without Raynaud or any autoimmune disease who were matched for age, gender, BMI, smoking, and cardiovascular comorbidities. And all the patients and the controls underwent dynamic PET myocardial perfusion imaging. And here you can see two representative set of images for on the left for a patient who has Raynaud phenomenon and systemic sclerosis, and on the right for control patients without Raynaud or autoimmune disease. And on the top rows, you can see representative short axis slices and long axis slices with the stress at the top and rest at the bottom, representative slices of the myocardium. And here you can see that there are no big perfusion defects. So the radiotracer uptake is homogeneous. And this is true for both the patient with Raynaud and systemic sclerosis and the patient without Raynaud. And if you record the blood pool and the myocardial radiotracer uptake over time, and you apply kinetic modeling, you can estimate myocardial blood flow. And here you can see that the stress myocardial blood flow is reduced in the patient with Raynaud and systemic sclerosis, and with normal rest myocardial blood flow, resulting in reduced myocardial flow reserve. Again, with severely reduced being less than 1.5. At the same time, the patient without Raynaud had normal stress myocardial blood flow, normal rest myocardial blood flow, and normal myocardial flow reserve. Here on this table, you can see that the matching process worked quite well. The patients were comparable to controls with regards to age, gender, BMI, and comorbidities. The time since Raynaud phenomenon diagnosis correlated inversely with myocardial flow reserve, as you can see on the left. However, there was no correlation between sedimentation rate and C-reactive protein levels with the myocardial flow reserve. As for the main results of our findings, you can see that for stress myocardial blood flow, patients with systemic sclerosis and Raynaud phenomenon, as indicated by red, had significantly reduced stress myocardial blood flow when compared to healthy participants. At the same time, they had significantly increased rest myocardial blood flow when compared to the matched control patients. And this, according to this formula, resulted in reduced myocardial flow reserve in patients with systemic sclerosis and Raynaud when compared to both the healthy participants and the matched control patients. At the same time, if you look at the light blue bar, the patients with primary Raynaud phenomenon had very similar stress myocardial blood flow, rest myocardial blood flow, and myocardial flow reserve values when compared to both healthy participant and match control patients. We also did univariate analysis to identify predictors of low myocardial flow reserve, and with this we found systemic sclerosis and prior revascularization to be associated with the low myocardial flow reserve, meaning MFR less than 2.0. And in this multivariate analysis, only systemic sclerosis was an independent predictor for reduced myocardial flow reserve. In conclusion, our results indicate that in patients with secondary venous phenomenon, systemic sclerosis was associated with reduced global PET myocardial flow reserve when compared to both healthy participants and to patients without RANO and autoimmune disease who were similar at age, gender, BMI, and comorbidities. Therefore, systemic sclerosis may be an independent predictor of reduced myocardial flow reserve. At the same time, patients with primary venous phenomenon had myocardial flow reserve values that were comparable to healthy participants and matched patient controls. Larger prospective studies are needed to validate these findings and to find out whether myocardial flow reserve has any prognostic value in patients with renal phenomenon. Thank you for your attention.